Hello and welcome. My name is Peter. I'm an emergency medicine resident from Denmark working in Sweden. And the last couple of years, there's been a lot of nuanced changes to the guidelines of anaphylaxis. And recently, I came across this new brilliant Australian algorithm that I'll present to you. So I figured I wanted to gather some of the information here in a small lecture called Anaphylaxis with Asthma Symptoms, or Anaphylaxis and Asthma Symptoms. As we will see, these two syndromes are quite alike, and we probably should, in the severe cases of both, treat them likewise. All right, so you probably think that you know everything you need to know about anaphylaxis, but I can assure you that there are nuances that I didn't know, and I thought I knew everything about anaphylaxis. So it's at least everything that's worth knowing as an emergency physician. So I believe that it's a good idea to go through this lecture, and at least just to know some of the links on the newer guidelines and in which direction they are pulling. Okay, so let's get started. As always, I always like to start with some of the links so that you can check out for yourself what I'm saying is right, or make up your own mind about it. So for acute asthma, here are some good foam links, and here are some guidelines that are current where I come from. Here's the Danish lung medicine guideline for acute asthma exacerbation, and here's the more internationally renowned British Thoracic Society guidelines. I would highlight, if you don't know how to use NIV, it's not a particularly good tool in asthma, not at least not as in other conditions, but if you don't know how to NIV, then this is a very good lecture about that. And a lot of the tips I'll use for the anaphylaxis with bronchospasm comes from a lot of these links, especially from this new, or to me at least, new algorithm and the homepage AMAX 4. I highly suggest that you check this out because I think they have some very important nuances, and both St. Emlyn's and Life in the Fast Lane has covered this if you want to get a short updated version on this algorithm, which is from Australia. Okay, then for anaphylaxis, there are these. It's kind of the same pages that go again. The EM cases, the IBCC, also first 10 EM here. But the guidelines here, I would suggest that you may check out for yourself, especially the UK guideline, which was posted in 2021, and a lot of the things that I'll be using is from this. But if you're from Scandinavia, and especially from Denmark, you can check out that there's an update for the 2023 Danish Allergological Society's guideline. If you're from Sweden or Stockholm, then you have this guideline that we follow, and they are quite similar. I think the Stockholm one is actually getting quite good in terms of medical recommendations. So please check that out as well if you're looking for dose related questions. Okay, so let's head into the lecture. So I want to take a bit of a different direction for this lecture because a lot of you know how to diagnose an anaphylactic shock, at least when it presents classically with skin symptoms and maybe hypotension and maybe even bronchospasm. But I want you to think as an emergency physician where there's different entry points into the same condition, right? Like if you have diagnosis of ACS or the illness script of ACS, you may have a entry point, the classical one being chest pain, but in the more recent years there's been a need for us to learn or relearn that the atypical presentations are typical with at least chest pain, and people with shortness of breath, or maybe even more vague symptoms, especially in women and elderly and neurological compromise like diabetes or maybe stroke patients. What we thought was typical, like chest pain, is not as typical, and the atypical presentations are atypical. That's a long way a long way around to just say that asthmatic symptoms can in isolation sometimes present with a very severe trajectory and actually with anaphylaxis. And I'll try to teach you some of the nuances, but mainly I would suggest that you check out the AMAX video for the more deeper dive into this. But let's say that we have a patient with asthmatic symptoms, wheezing and maybe bronchospasm with a prolonged experium. And I guess we can just check out, first of all, whether has it been sudden onset? Because most of the asthmas that are non-allergic and the COPDs that may also wheeze, and some of the other conditions that may also wheeze, they're not sudden, and they don't have specific features for anaphylaxis. There's other things that we might look at as well. Such as age. Usually, the older you are, you're more likely it's COPD more than asthma. But in general, if it's not sudden in onset and there's no anaphylaxis features, which we'll come back to, what they are, then usually it's more like, is this COPD or asthma, or different differential diagnosis that may also present with a wheeze, but it's not bronchospasm. But it's, for the specific question of whether this is COPD or asthma, it's important to realize that your friend is the ABG and the PEF, the peak expiratory flow. And like a good mnemonic is that the COPD patient that is in a bad way usually have a pH change. That's the thing you want to look at for them. And the asthma patient usually has a PCO2. There's a PCO2 that's the canary in the coal mine for the asthma patient. Whereas the COPD patient will usually tolerate quite high PCO2s, right? And may even habitually have quite high PCO2s, but a normal pH. If the pH is normal and their condition seems good, then it's probably quite a stable condition. Whereas in asthma, if the PCO2 is the one that you want to look at, if an asthmatic patient is not hypocapnic, like with a low PCO2, then it's an emergency. Like it's a very time critical emergency because they're tiring out if they're becoming normocapnic. The problem I often find is that if your asthmatic patient they're wheezing, but they're normocapnic, and they don't feel too bad, then it's kind of hard to know whether they are tiring out or not. And of course, you can look at it clinically if you calm them down. But another way you could look at it is if you do a PEF on them and just to see whether or not they are doing as they should. Most times you can tease it out clinically, but one of the other problems is that we don't see asthma that much anymore, because the better the primary care healthcare system is in a country, the less likely you are to see asthma, because you can almost prevent all the exacerbations for asthma if they are treated well in the primary care sector. And in Scandinavia, we usually have a quite good primary care sector, so we don't see asthma exacerbations that much. In the course that I'm teaching, the emergency medicine core competence course, we have actually a case where it's like a 50-year-old guy coming in with a PCO2 of maybe like a normocapnic PCO2. And if that is a COPD patient, or maybe a slightly high PCO2, and if that was a COPD patient, like I think the guy is maybe an alcoholic and maybe have smoked his entire life, but it says, like on the chart, it says asthma/COPD, as it often does. If you go the COPD way and expect that, PCO2 should be high, and that's kind of classical COPD exacerbation. Well, then you won't see that then you, if you assume that he's COPD just because he's maybe 50 or on the older side of the spectrum and has smoking related issues, then you will mistreat this patient and he will go into cardiac arrest in the case. What you always wanted to consider whether or not this is asthma, especially in the younger patient where it says asthma/COPD. And if they are normocapnic, but they do look in if they are normocapnic or just slightly hypercapnic, but look very to be in a very bad way with a high work of breathing, then you should maybe consider treating them as asthmatics instead of as COPDs. I won't go into details with the treatments, but of course COPD would usually need salbutamol in combination with ipratropium and prednisone and NIV treatment, and then work up for what kind of condition might be provocating this condition. It may be infection. Sometimes it may be a minor pulmonary embolism or pneumothorax in the rarer cases. And we have to remember these lungs are they're more frail. There's not a lot that needs to be done. Maybe small pulmonary embolisms can make them tip over and exacerbate. There are some studies out there suggesting that maybe 10 or 20% of the COPD patients may have pulmonary embolisms. With whether or not this is clinically significant ones or if it's just an association, it is hard to tell so far, and it's hard to clinically use this information. But it's just saying there's different kinds of exacerbation that we need to be aware of here, and the NIV would be the main treatment here, and especially the NIV with a high delta, like a CPAP of maybe 2 to 5, and then a IPAP of 10 to start with. And then you will increase the IPAP so that the delta between the CPAP and the IPAP goes from, well, if it was CPAP 5, IPAP 10, then the delta is 5, like the delta between the two. 10 minus 5, and then you'll just increase the IPAP until you get a satisfactory level. But that's the NIV for another time, right? The asthma, will go into details of how to treat the asthma later on. But in general, it's continuous salbutamol, maybe also with ipratropium, and of course prednisone as well. Finding the causes as well. So in a lot of ways they're quite similar to treatments, but the aggressiveness with which you treat the asthma patient is different. And how you see if they're in a bad way is also different. Okay, and especially as we'll see, if they have anaphylactic symptoms, then if they have, then the treatment is quite different, and it's more towards the, it should be more towards the anaphylactic algorithms. So if they're, and how do we know whether they are anaphylactic or not? Well, some cues are if they have sudden onset symptoms or rapidly progressive symptoms, meaning within a couple of minutes to maybe an hour or two, or if they have specific anaphylaxis features such as such as we'll go through them now, or if they present in extremis, like they have a silent chest, then you may, instead of treating them as a semi-stable asthma patient with an exacerbation, you would probably be better off treating them as a anaphylactic patient with IM adrenaline, because you won't be able to get anything into their lungs anyway by inhalation nebulized beta 2 agonists. All right, so what are the symptoms of anaphylaxis? How do we recognize this? And this is kind of, well, there's different guidelines, and I'll show you one of the Australian guidelines, I'll show you the UK guidelines, and then I'll show you the World Allergological Organization guidelines here. And they are quite similar, and I'll come with my own summary of them, but here are the guidelines. So this is from the AMAX, and I think they're using something, I can't remember the name of the organization, but I think it's an Australian one. And they say like acute onset of symptoms involving mucocutaneous region and symptoms either reduced blood pressure or respiratory symptom compromise after a likely allergen exposure involving 2 or more systems with these, and after a known allergen exposure, evidence of reduced blood pressure. So these are 3 ways into the these are 3 ways into anaphylaxis. So either this, or this. And this is a bit different than the British one, which would be also the sudden onset and rapid progressive onset, and then with ABC symptoms. And then you have the ABC symptoms here, and then they don't signify the skin or GI symptoms that much. It all depends on the ABC stability of the patient and the suddenness of the onset. And then this is the World Allergy Organization 2020 guidelines, and either acute onset laryngeal involvement, bronchospasm, or hypotension. So that's also acute onset A, B, or C. After exposure to a known or highly probable allergen, or acute onset of illness minutes to several hours with simultaneously involvement of skin, mucosal tissues, or both. And they also need to have respiratory compromise, reduced blood pressure, and severe GI symptoms. Yeah. So and for my like idea in my head for the definition, because they're very similar, but there are some differences, as you can see from these just the 3 guidelines. I'm sure there are more guidelines that are a bit different as well. So for me, I would just make it simple. This was the name of the Australian one. I didn't remember. NIAIDFAN. And so for me, it's like sudden onset or rapid progressive symptoms within minutes to 2 to 3 hours. It can be with a known allergen, but for me it doesn't have to be, because a lot of the times, or sometimes, there's no known allergen, and it will never be found. And I guess the timing kind of depends on the trigger and how high a dose and what kind of route it has been used for, as you'll see here from the UK guideline. And so a parenteral route, like into the bloodstream, causes a more rapid onset of symptoms and reactions to an ingested food or drug. Well, I wouldn't hang my hat on any of this. It's just like small likelihood ratios in one way or the other. The most important thing is the sudden or rapid progressive onset within 3 hours, but usually minutes if it's a type 1 reaction, especially maybe if it's parental. And then this should be combined always. It's not anaphylaxis if it's not combined with one of the ABC problems, which would be airway compromise in form of either laryngeal symptoms like stridor, like bronchospasm, hypoxia, increased work of breathing, and so on, or C problems like hypotension, cold and clammy skin, and so on and so forth. And then what we often see in the emergency department is people coming in with rapid onset and mucosal findings, but not much else. And mucosal and skin problems may be angioedema. It may be some other involvements. But if the angioedema is not compromising the airway, not causing an ABC problem per se, meaning that they're stable, then it's not really considered anaphylaxis. That doesn't mean that it's not an emergency. Like if you have someone with an angioedema that is like with a tongue that is filling up the entire mouth, then it's a highly problematic situation, because the airway management of that patient, if they deteriorate, will be highly compromised, and they may be what Rich Levitan would call an surgical inevitable airway, where you just go to cut the neck if they deteriorate. So that it doesn't mean that they are not problematic, these mucosal findings sometimes, but if it's purely skin symptoms and it's sudden onset, but there's nothing more happening, well, then it might have been a type 1 reaction, but it's not an anaphylactic reaction, right? And it's important to kind of separate these two. But it's not entirely possible always to do that, because it's of course on a spectrum, and the patients with a type 1 reaction, meaning within a couple of like minutes to maybe 2 or 3 hours, that's the main thing for them is they need to see an allergy specialist to maybe work up what kind of things it is, because they may develop anaphylaxis at a later point because of sensibilization with increased exposure. Not always, but just they need to, a lot of these, if it's a type 1 reaction happening suddenly, they need to be worked out, but it's not anaphylaxis. And then the GI symptoms, and this is quite variable between guidelines. And in the UK one, they don't. I mean, if they have sudden onset of GI symptoms, but it's nothing else, and maybe mucosal findings as well. Well, it's really depends on the definitions. A lot of the times, we probably should just observe these patients, especially if it's rapid onset or rapidly progressing. And we would probably take a serum tryptase and work them up with allergy specialists. But if they don't, during the observation period, develop any of the ABC symptoms, then probably they can just go home without any further workup, right? But I sometimes find it difficult if they have a lot of these symptoms and are progressive, but they should not be considered anaphylaxis, and whether or not they should be observed or how much depends on clinical gestalt and clinical or local culture. Because to my knowledge, there's not a lot of guidance out there for these symptoms, not in terms of treatment either. Okay, so the take home from this slide is sudden onset with ABC problems. That is something we should consider for anaphylaxis. Even if the sudden onset is bronchospasm, or sometimes it's hypotension, so they may be syncope as a presenting symptom. So you have to keep an eye out for sudden onset A, B, and C problems that may be anaphylaxis to begin with, right? All right. But let's just for these symptoms, because we do see them a lot, let's just show here what is not anaphylaxis. And I guess from the UK guideline, at least, it's pretty clear that rapid onset of progressive isolated skin and or mucosal problems without ABC problems, that is not anaphylaxis. But however, if you're in doubt, and give adrenaline, or I would say like observe them for development of the ABC problems until they're stable. So what they say in the UK guideline is this: GI symptoms, well, gastrointestinal symptoms such as nausea, abdominal pain, and vomiting, in the absence of A, B, or C problems, do not usually indicate anaphylaxis. Usually, they're choosing the language here. Abdominal pain and vomiting can be symptoms of anaphylaxis due to an insect bite or sting, though. So again, GI symptoms, it's hard. I would observe them for ABC symptoms, and if I'm in doubt, then I'll give them adrenaline. It's a little bit different with the skin mucosal symptoms. Sometimes they have generalized urticaria, angioedema, or similar, but these should not be considered to be anaphylaxis, because if they don't have the A, B, and C problems. That's a bit more clear. So GI symptoms, that's a bit on the fence, but skin and mucosal symptoms are almost never anaphylaxis if not with an A, B, or C problem. And I just talked about angioedema, and just to tell you about a little more about angioedema. If you may want to give adrenaline for angioedema anyway, but a lot of the ones that we see are not non-allergic angioedemas. They're more likely to be tryptase induced, I think it's called, angioedema, or hereditary. Or I was like, the non. So if you give them adrenaline, it won't work. So the main treatment for these angioedema is airway management and observation for airway management. There are these specific drugs that you can give, and I forget their names because they're really expensive and quite low evidence to use, unless you have these specific C1 esterase problems. But in general, like for angioedema, just it's observation for airway compromise because most of them will not really respond to adrenaline. And if they have a really swollen tongue, I would do that quite quickly. All right, and then they say confusion. Well, a confused patient may arise because of other causes. Well, yeah. So it's always a question of clinical gestalt, right? It's harder when the patients are older because then there is more other causes, a lot of other causes that may be the reason for the confusion, right? In younger patients, it's less is more that are more like what we call less complicated because they have less comorbidities. Then a confusion is more concerning, I would say. And here you have this from the UK guideline. It is a spectrum, so you can't say that's why they're weighing their words as well. But in general, if it's mild, localized, and it's localized skin symptoms and it's not generalized skin reactions, then it's not anaphylaxis. Going to the more generalized skin reactions, they still say it's not anaphylaxis if they don't have ABC problems. But once they develop ABC problems, then it becomes anaphylaxis. So they pull a line here, but it's a spectrum, they say as well, right? So I would, if they do have rapid progressing symptoms like skin, urticarial skin lesions, then I would probably observe them. And if in doubt, take the tryptase within 2 or 3 hours, usually 2 hours, and then give imidrolin. It's not dangerous to give imidrolin. It's very, very undangerous, so do that. And then some risk factors. Some of the patients may be resistant to imidrolin. That might be if they were on beta blockers, because the beta agonism is being is being antagonized by the beta blockers. Another risk factor is if they have asthma symptoms. This is what this entire lecture is kind of about. So we'll get back to that. If they have a high dose of the allergen, if they took a high dose of whatever it is, maybe a lot of peanuts, or if there's a delay to the adrenaline if they have anaphylaxis, that's a problem as well. So it goes without saying that the longer you wait, the higher the risk is for mortality if they actually have anaphylaxis, because the airway would be harder to manage, and so it's a tricky game to wait, especially if they don't have any ABC problems. Like they may progress to this in the observation, and should we give it early instead of not? It's sometimes hard, I think. So I mean, if you're in doubt, give it, and then you can always recheck if they're doing fine, and then take tryptase to see if it actually was an anaphylaxis or not. And I know the tryptase is not perfect, but follow up with an allergy specialist, and then they can decide whether or not it was or not. All right, I just wanted to show you some of the, you probably know these guidelines, but these are the new guidelines from the UK 2021 and the Danish one here as well. And I'm just saying they're quite the same. What they emphasize is that once we've diagnosed anaphylaxis, then we'll give them IM adrenaline or epinephrine, and we have to also do like more basic stuff. You have to lay the patient down, either sitting or like with the legs up. There are some studies showing that they have a low, I think it was low preload, so they can get fluids. It's a good thing to give them fluids. That's why you also want to raise the legs, and actually then you just if they don't become better with IM adrenaline, then you give another bolus after 5 minutes, and that's kind of what both these guidelines say, right? What they don't say, and that's I think it's really important. What they don't say is don't give. We'll get back to that here. What they don't say is now specifically that like antihistamines should not be given, and that they have no routine use in in anaphylaxis. It's only a drug for if they're itchy. And they should especially, I mean, if someone wants to give antihistamines or prednisone early on, or if during the anaphylaxis case, then well, I don't want to. I don't. That's not a hill I want to die on. As long as it's not something that is getting prioritized, it's something that you give along down the road, and not as like give adrenaline first, first, second, and third, and then afterwards you may consider giving some of the other less effective drugs. And these antihistamines are totally ineffective, it seems now to be the conclusion. And also prednisone in non-asthmatic anaphylaxis, they have no real place. Like the argument for corticosteroids was that it may reduce the risk for the second wave, like you have the first wave of anaphylaxis, and then some patients will develop after a couple of hours to days a second wave of anaphylaxis. And it was thought that the prednisone may decrease this risk, and it seems in the UK guidelines now that it doesn't, and they recommend against it in the emergency department at least. You may give it at a later point, but if they have asthma, then still I would give prednisone and betamethasone, and I might consider it as something that you should give early on. But still, adrenaline comes first, second, and third if they're in a bad way. Okay. And then let's say that they actually turn around and they can become better. When can we release them from the emergency department? Well, there's a bit of variation here, and I guess the evidence is not that good on it. But so in Sweden, I just brought in the Swedish guideline here from Stockholm. They graded in grade 1, 2, or 3 type anaphylaxis. So it's depending on the severity, and that's the same in the UK guideline. Depending on the severity, you want to observe them for longer if it's a severe reaction. So severe reactions would usually be with hypotension and would usually be with repeated doses of adrenaline or cardiac arrest. I think it says in one of these as well. Or if they have like continuous, like the allergen cannot be removed, then of course you want to usually admit them even for longer than 12 hours. But most patients will fall into this grade 1 or grade 2, and in the UK one, it's 2 doses of IM adrenaline to treat the reaction, or if they have had a biphasic reaction like the second wave before, and you'll have to wait for at least 6 hours. But in the new, like the lowest level here is if they had anaphylaxis, then it will have to be observed for 4 hours in Sweden or in Stockholm. But in the UK guideline, they can be discharged after 2 hours of observation from if they live up to these criteria. They have a good response within 5 to 10 minutes to a single dose of adrenaline, and they have a complete reduction of symptoms, and the patient has an unused adrenaline at home, so they can use one more, and they know how to use it. And there's and there's an adequate supervision following discharge. So they have someone at home who can administer the adrenaline as well if they become unconscious. Well, um, probably depending on how you will grade it, whether it's symptoms or the amount of adrenaline that you're given. Just saying that this is a low evidence zone, but and it's very much a local protocol. I think the UK one is very sensible, depending on how many doses that you clinically thought is important. Then you should probably observe them. But if they turn around very quickly and they know everything they need to know and have everything they need to have, and they're doing fine, then probably they can be they can go home. All right. Other stuff that we want to know. Well, the tryptase I've talked about within 2 hours is not a perfect test, but it's a good test to know, and it has to be taken within the 2 hours. And I think you need to take a baseline one as well. I'm not sure when you have to take that. I think some guidelines said after 6 hours, but I know some allergy centers then also take them for considering what the baseline has been. You also, if you when they go home, they have to have an EpiPen prescription. Sometimes they have to be taught how to use it, like blue to the sky, orange to the thigh. That's a mnemonic usually, because your orange bit is where the needle is, and the most, and they need to know that it's the if you part the thigh, if you make the thigh go into, like, or if you separate the thigh into three groups, like 3 equal sizes from proximal to distal, then it's in the middle. You have to in the middle third, and as then you have to put it, and then in the anterior lateral side. So a bit in the middle, and then a bit lateral. In the middle, and then to the lateral side. So middle third and anterior lateral side of the thigh inside the muscle. And then the reaction, it should help within 5 to 8 minutes. After 5 to 8 minutes. But if it's subcutaneous administration, then it usually takes 20 minutes, and that's why it's really important that they actually are taught how to take this. Then all of these will need allergological follow-up, and avoid the suspected allergen until they can get that follow-up. Okay. And for my sparsely allergy outpatient experience with pediatrics, there's no test besides exposure to the allergen that can perfectly, or that can with high certainty tell you that you are allergic to it. Like, you can be sensibilized with all these, like all the tests, all the allergy tests, like with blood samples and with skin tests and so on. To my knowledge, only say whether or not you're sensibilized to it. Of course, you can have a big reaction to it, and it's highly likely that if you have a big reaction to it, then probably you are allergic, but that doesn't mean that you are anaphylactic to it. It's only when you're exposed to something. And that's why in the pediatric department where I worked, once we had a suspicion for a child, at least, whether they were like highly allergic or not, then they would come in on a day, and I was usually on shift to administer adrenaline to them. The nurses would give, like, if it was X that they might be allergic to, then they would give the child X as an exposure test, like a purification test, and then observe them for a number of hours playing around in the department, and then sometimes they would develop bronchospasm and would develop all the anaphylactic symptoms, right? And then, then the test was positive, and then they knew they really had to avoid those. But we did that in cases where there was doubt, right? So the only, like, when it comes to allergies, to my knowledge, the best test is exposure in a safe environment. All right. So what about, and that's really the main thing about this lecture and the AMAX 4 lecture, which I encourage you to see, is when it doesn't work with this first part of the algorithm, you've given 2 times IM adrenaline, but they do not become better. That's the nightmare scenario, right? Because that's outside of most guidelines. But as emergency physicians, we need to know this, because this is our like the responsibility. That is our expertise area. And if the patient or if the patient presents in extremis, you can check out in the links in the link page that I started referencing to the EMU 365 asthma lecture, where they present that really like an extremist case, or the SMAC lecture by, I think, Heini Malamat. He also presents one of these cases. So like in the extremists where they hardly have any breath sounds, they're unconscious. What do you do then? Okay. So this is where the AMAX algorithm comes in, and sadly the MAX stands for the authors. I think it's called Mackenzie. The author's child that was sadly succumbed to his injuries after a severe anaphylactic reaction that was handled suboptimally, and that's why he wanted to make it clear how to do this in a kind of a Elaine Bromley kind of way, with non-technical skills and with like what you have to do, and with human factors, and that's the entire thing. So I encourage you to check out his page and his lectures on this area. So if they're in a bad way, what you do, and this is the patient with asthmatic symptoms or the patient with anaphylaxis, okay, you will do this. And why these are important, I'll go through this, but why this is important is because at the time, the asthmatic patient has a very, like, if you, I cannot remember if it's Purseu's law of pressure through a tube or whatever it is, but if the caliber of a tube, like the like the bronchioles, and like the entire lung tree, if they change just a few millimeters, then the flow through them will decrease significantly, right? So small caliber changes will make it they make the asthma patient deteriorate really fast. So they can go from looking really well to looking really bad in a quite quite fast. The majority of the anaphylactic patients actually die from B problems, especially the young ones, not C problems. There's two groups with anaphylaxis. There's the younger ones, like from maybe like childhood and maybe onto young adulthood. That's usually food allergies, and they often have asthmatic components, more so than maybe the elder ones. And the older ones are usually more likely to be iatrogenic, like medication allergies. But if they die from usually B problems like hypoxia, the bronchospasm, and not actually from the C problems, according to the AMAX page. You can check it out here. I have the link here. All right. What is important here is IM adrenaline, from when they crash, like they're not breathing, and then you have 4 minutes until they could become like the brain can only sustain 4 minutes without oxygen. So it will begin to die after that. So they will develop permanent brain injury after 4 minutes of totally deoxygenated blood. And the 4 minutes is really important because the IM adrenaline that we just talked about, it takes 5 minutes or more, usually 5 to 10 or 5 to 8 minutes to work if you administer it correctly. If you do not administer it correctly and you use it subcutaneously, or administer it subcutaneously, which is easily done on especially someone with a lot of body fat, or in a stressful situation, then it will take 20 minutes. Okay, so if they present to you in like unconscious or almost unconscious, then it's then it's not IM but IV that is the what you want to give. If you have if you have a line on them. If you don't have a line, then I guess then you'll have to use IM, but until you can get a line. And you will drill them with an intraosseous, if that's the case. All right. So the adrenaline, as we just talked about. So you have given them already. If you followed the algorithm before, then you've given them 5 or 0.5 milligrams if it's a big adult, 0.5 milligrams intramuscularly. You give them twice with 5 minutes in between. But if they present in extremis, then you skip that and give them IV adrenaline. I'll show you in a little while how to give that. And the dose is 1 microgram per kilo IV push dose every minute until they improve. If they do improve a little bit, then you can stretch out the 1 minute to maybe 10 minutes and reassess, or maybe 5 minutes depending on the situation, right? So for a big person, that might be 100 kilos. That would be 100 micrograms IV push every minute until you can establish a intravenous an adrenaline infusion, and the anesthesiologist has to have come. And a lot of us who are emergency physicians, especially in Scandinavia, we're usually we're not that used to using vasopressors, and especially not intubating patients. But this is a situation where we may have to. I'm not encouraging anyone to intubate patients just anytime at all. I think we have great experts doing that, and I've done an entire lecture series on advanced airway management because I think we need to know it, and we need to be able to discuss it with our colleagues in anesthesiology. But I don't think we need to do it if we have them available. And most places in Scandinavia, I'm not saying all places, but most places in Scandinavia, you do have them available in a timely manner, and they are the experts. So from the patient's perspective, who do we want to be intubated by? Mainly, or usually, that's the anesthesiologist. But from the patient's perspective as well, if you only have 4 minutes until you become hypoxic, and how long does it take to get down the anesthesiologist, especially if they're doing something else? That's too long. So we need to give this adrenaline IV. We, not the anesthesiologist. Then they have to become mad at us, and then we can show them the evidence if they want it. And you can also check out Cliff Reed's How to Be a Hero lecture if you want to give some advice on how to go outside of the guidelines if you really need to, like be a hero, as Cliff Reed would maybe not say, but that's what the lecture is about. And like these situations where we have to do it, we know we have to do it, and we cannot call for help because then it will be too late. So we give it IV until they improve, and I'll show you how to mix it in a little while here. Then, if they are totally unconscious, if they're unconscious, or maybe even if they are going into cardiac arrest, usually they will not breathe, and then that's kind of a CPR situation. Even though they may have a pulse, this is the time where you want to intubate them. If they still have a pulse and they're still awake and they're like kind of stabilizing on this, then you may try to nib them if you want to, or just keep giving them adrenaline and all the other drugs that we'll talk about. But if they become unconscious, then you'll go into CPR mode. And we know in trauma, we don't pump on a empty heart because there's nothing to pump around. Or at least you have to do other stuff that is more highly prioritized. Like in trauma, you want to do a bilateral thoracotomy, you want to do a pericardiocentesis, you want to intubate them, and you want to maybe do a lateral or a total clamshell if they have pericardial effusion and you want to give them blood. That's kind of what you can do in a cardiac arrest situation in trauma if they're not far too gone. So there's a lot of these algorithms where you more and more algorithms going away from the standard putting pads on the patient and doing compressions. That's really important in the undifferentiated cardiac arrest, because if they have a if they have a rhythm that can that can get electricity, then it's kind of then they have a great survival if you can, especially if it's not refractory. But but these hypoxic cardiac arrests in anaphylaxia, you have totally, like, most of them die from B problems. Usually that's the case as well. So you're just pumping around deoxygenated blood. So prioritize to intubate them, and you may be the one that has to do that, because again, you have 4 minutes. If you have to give them a muscle relaxant, maybe you can give them rocuronium, if your nurses are comfortable with that. If they're totally hypotonic, like they don't have any tone at all because they are in cardiac arrest or almost getting into cardiac arrest, then I guess you can try without. But you have to do the first pass success, and you have to, like, who does it? Well, in the lecture they say it's the best person in the room, right? Because you don't have time to get anyone else at this point. Not for 4 minutes. So you don't need to get ketamine and propofol. It will be coming afterwards. You will be giving it afterwards once anesthesiology has come. And if you get the tube in, again, I have an entire lecture series about this if you want to know the details. But if you get the tube in, then you'll back ventilate the patient initially. You will not you will not put them on a ventilator right away, and it will feel like a brick. You will feel like putting air into a brick. And that's once you've successfully intubated them and secured the tube, then you will press on the chest, deflate the chest to get all the stacked breath out of the chest, right? So press lateral chest pressure, just one push, and once you've ventilated them and the drugs are working, and then you deflated the chest, then at some point you can put them on the ventilator because they will become easier to back once the drugs are working. But it's so important that you get oxygen into the patient, and at this point, that's why we probably should do the intubation here if we're the only one there, and the anesthesiologist is not there yet. Optimally, they will be the ones doing it, but if they're not present or they cannot make it in 4 minutes, then we are the ones also giving this adrenaline. What they say in this lecture is that in the rest of the cardiac arrest literature, we have gone to more like LMA or back valve masking, because there were a couple of studies in the last couple of years that said that LMA and back valve masking are not inferior to to intubation with a normal tube. But it's not a secure airway, and in asthma, the pressures are too high in the lungs, so there's a high risk of leak if you don't have an ET, like a normal tube, but instead have an LMA. There's also a high risk of aspiration, among other, because you may be blowing with these attempts before doing the intubation. You might have blown up the stomach because there's such high pressures in the thorax. Because you're giving them high pressures during the back valve ventilation, there's a high risk of pneumothorax. So do check out chest drains and put them in if you need to. And other stuff is, well, once you've done this, then you will do the rest. Then you will do all the other meds, bronchodilators, steroids, magnesium, ketamine, inhalated adrenaline, and so on. So in the events of a patient presenting in extremis with either asthma or anaphylaxis, you give them, because there's no time for IM, if you have a line, you give them IV 1 microgram per kilo per minute until they improve. You want to intubate them with a ET tube first pass success. You may muscle relax them if you have to, if you can. Maybe choose rocuronium. I think it's 100 milligrams. Just give it. And then if that doesn't work, you'll do a FONA, a front of neck access, because you only have one attempt. Sometimes the airway is so compromised that it's impossible to get a tube in because of edema. Then X is for use extreme ventilation, right? There are high pressures here, and you'll do it with high pressures, and then you'll couple it to the ventilator afterwards. Use extra bronchodilators, yes. Once you can, you will use the bronchodilators, but if they're presenting extremists, then it's hard to do bronchodilators because they will not be breathing, and they will not get into the lungs effectively, but afterwards you will. Then use extra vasopressors. Yeah, you will couple them. While you're doing this, you have someone drawing up or preparing an infusion, and consider pneumothorax. And remember, 4 minutes is all it takes for the brain to die, for the person that is in front of you to not be the person anymore. In general, I think it's sometimes forgotten, also in this guideline, that calmness in the room is really important, and Heini Malamet talks about this in this MAC lecture. Please look at that up as well. I think it's really important to have a calm room as well, especially for the asthmatic, so that they're not psychologically stressed more than they have to, because that will negatively influence their breathing. Okay, just to say that the UK guideline has a similar refractory anaphylaxis guideline. That is just the part 2 of the guideline I showed before. But I think the importance of the AMAX is that when they present the extremists, you start with the refractory guideline. You don't start with the IM, or you can do both at the same time, but you have to consider, like, they only have 4 minutes if they're really in a bad way. Okay, so the last part of the lecture is just how to adrenaline. And because I think this is a core skill for emergency physicians, to know how to draw up adrenaline, not just for anaphylaxis and asthma, but also for sepsis or other conditions where we need to give it now, and we don't have the time to wait for the anesthesiologist, even though they will be coming, and we don't want to be cowboys. We don't want to use stuff that we're not used to, but we also have to be responsible for actually being experts in the emergency department, and we want to know how to use this if we need to use it until anesthesiology is coming, right? So if we want to give it IM, as we talked about, then you have this ampoule is 1 milliliter of 1 milligram per milliliter adrenaline. This is the standard. You can think of it as this is like a really small dose. This is what goes into the thigh. The bigger dose, as we will talk about later, is what you call crash cart epi. That's like 10 milliliters. There's the same concentration, but in 10 milliliters. And that's what you use for cardiac arrest, where you give 10 milliliter boluses IV. For this, the doses for this, well, this is the concentration you use, and the doses for this I'll show you down here in a little while. I just wanted to give you the mnemonic that we use in Denmark sometimes to remember this. So we use it's a 0.5 milligram for the half dead, like anaphylaxis, and it's a whole milligram for the whole dead or the totally dead, which would be cardiac arrest. That's the adrenaline doses. And then at our shop we often see, we don't not often see, but maybe a couple of times a month, there will be a child with some kind of symptoms, and sometimes that symptoms is allergic or anaphylactic symptoms. And even though we're not a pediatric hospital, we need to know these doses because more than once we have needed to use them in our department or for small children. So the way I remember it is 0.15, 0.3, and 0.5. It's like this one is like in my mind always. So it's like half that and half of that, kind of. So the Danish guideline says 0.3 to 0.5, right? Whereas the British guideline says 0.5 for the adults. Whether you give this amount or this amount, I mean, it doesn't really matter. It's quite, it's not dangerous to give it intramuscularly. So I usually actually give the higher dose if they're adults, and only if they're really really small, I will give the lower dose. And then for children like below the age of maybe 10, something like that, I'll give the 0.15 dose. But the problem is sometimes with these doses is that, well, I don't like if you have a child in front of you and you only have an adult EpiPen, then I would probably give this dose, or I'll give half that dose. It's very undangerous, and it's more dangerous to not give it in most cases, right? So just most people become tachycardic, and it will feel a bit uncomfortable for them when they get this. So if you can, try to like aim at the dose for their weight, but if nothing else, then just give what you. It's better to give than not. And we talked about where to give it. It's the if you part the thigh into thirds, then it's the lower third, the upper third, and then this is the middle third here. And then you have the medial aspect or the lateral aspect, and this is where you put the needle, the anterolateral aspect of the thigh, blue to the sky, orange to the thigh, right? So the EpiPen has an orange side with the needle that has to go into the thigh. There are different needles. Like this is quite a there's a lot of subcutaneous tissue here. So there's a lot of so you need to be aware that this is a patient where you might be in an increased risk of doing it subcutaneously, and you may want to give it IV if you're in doubt. Okay, so that's the IM route. 0.5 milligram of adrenaline here, and as we said, give two times IM within 5 minutes. If no improvement, then give IV. And if they're presenting extremists, then you can skip the IV IM if you have an IV, or you can give it simultaneously. So give IM and simultaneously give IV as well, so then you know they're getting it, and then prepare to intubate if they're in that bad way. Then how to give adrenaline IV. Okay, and as we said, what we're looking for is 1 microgram per kilo per minute. That's what you'd give them for with it presented in extremis. So you give them. And this is like the core skill for adrenaline. What you need to learn here. So you have what you call enkelspett in Swedish. Like you're diluting it a tenth. So you take 1 milliliter of this, 1 milligram per milliliter, which is like 1,000 micrograms as well. You can think of it as that. And then you put it into a syringe. So you have 1 milliliter of that. And then you fill the syringe with the last 9 milliliters should be normal saline. Okay. Then you have a 10 milliliter syringe with now a concentration diluted a tenth. So 0.1 milligrams per milliliter or 100 milligrams per milliliter, right? 100 micrograms per milliliter. You can actually dilute that one more time, right? And that's what we call a dubbelspett in Swedish. It's doubly diluted. And then you take this syringe that you just prepared, and take 1 milliliter of that, and in a new syringe, and then and then you'll add 9 milliliters to that, and then you'll have a new syringe with which has 100th of the concentration of this. So 10 milliliters of 0.01 milligrams per milliliter, or 10 micrograms per milliliter. Okay. So when you do this once, this is also what you call crash cart epi. So the entire dose of this, like everything that's in here, is just the volume is more, but it's the same concentration, right? So giving this entire syringe in a cardiac arrest will be giving 1 milligram, and this is the same as giving this, but when you give it IV, you wanna have a bit higher volumes to be sure that it's giving in the correct way and everything is going in. All right, so that's the main way to do this, right? To prepare these drugs. And there's a video on both EMCrit who's done this, and others and also on the AMAX 4 sites. There's also a demonstration how to do this. This is a core skill that we need to know. So once we have our preparations, it's practical for the bigger adult to use the cardiac arrest, and you can just use the crash cart epi as well. If it's a 70 to 100 kilo patient, then you'll need a 0.7 to 1 milliliter per minute, and that's like 1 milliliter is quite hard to 0.7 milliliters is a bit hard to it might be a bit hard to measure, but at least 1 milliliter would be easy just to give 1 milliliter. If you're in doubt, or if it's hard to measure out, or a quick way, a new tip from EMCrit recently is to just take this syringe and then put it into a 1 milliliter syringe, because then you can give 0.7 easily if you just use the 1 milliliter syringe, right? So take this and then put it into a 1 milliliter syringe, and then you can easily dose it. That's one way of doing it. The other way of doing it is doing a double spätning, or a double dilution, so that you have the blue one here, and then you can give smaller doses, especially if it's a very small adult or kid. Then either doing the 1 milliliter way or doing the double spätning, the double dilution, because then each milliliter here will be each milliliter here would be the same as in the 1 milliliter syringe. So yeah, whichever way you do it. But I need more. The problem with this is that it takes time to do this solution, and you don't have too much of the solution. So you can't do this. This is the method that we just went through. You can do this if you have these 1 milliliter bag, 100 milliliter bags. Then you can take this and just put it into a 100 milliliter bag, and then draw from this, and then you have a double spät really fast. And this is a double spät then. And you do use a double, so you can, in other scenarios, you'll usually give 20 to 50 micrograms per minute, and here in anaphylaxis you'll give 100. So it is something that is used in the ERC guidelines as well. So it's important to know this and how to do this in your department. Then you sometimes hear about the dirty epidrip as well, and the dirty epidrip is putting 1 milligrams per milliliter into a 1 liter solution of normal saline, and this is thought to be some kind of temporizing measure until you can get an infusion going in a septic patient, for instance. This is actually what it's not a word this, but you can call it triple spät or triple diluted, because this yields a 0.01 microgram per milliliter, or in each milliliter there's just 1 microgram of adrenaline. So Salim Mersey on Rebel EM has these great YouTube videos that I encourage you to watch, all of them. But he has 2 videos on dirty epidrip, and he says that if you make it run totally open, wide open, then if you have a microdrip, And I'm not sure actually if we have micro drips or macro drips, but if you have a micro drip, he says it's like maybe giving 20 to 30 micrograms per minute. That's underdosing in our case of the anaphylaxis, because we want to give maybe 50 to 100 depending on the size of the patient. If it's a 70 kilo patient, then it's underdosing. If it's a 20 to 30 kilo patient, then it's not underdosing. But if you don't have a micro drip, and I'm all of our all of our ones have some kind of this kind of micro drip kind of a solution. So, but if you have a solution where you don't have micro drip, then giving it wide open, apparently it will give you 100 micrograms per minute. He actually discouraged you from using a dirty drip. He rather will like you to do a bolus in one of these ways because it's more accurate, and then doing it every minute. Okay. So how to do the inhaled adrenaline? Well, um, according to the UK guideline, if you have bronchospasm, of course, or upper airway obstruction, or whatever, you need to give nebulized adrenaline in anaphylaxis, then you'll actually take a 5-time dose of this, and then you'll put it into a nebulizer, and you'll give it like that. Okay, so that's the nebulized adrenaline. Okay, then what do you do if you have asthma without anaphylaxis? Well, then and you can check out your own guidelines for this, but in general, you'll monitor them for SATs and PEFs, like peak expiratory flow, respiratory frequency in Swedish is andningsfrekvens, and you'll check the ABC signs as well. You'll have a calm room, and you'll give them SABA or SAMA. Continue if you only have SABA, you give them continuously. In this dose, maybe 2 milliliters to begin with, like bolusing their doses to begin with. In pediatrics, we call it a rocket when you give it like maybe 10 or 12 puffs in one dose with a spacer or an inhalator. Or you can get their own inhalator for 4 or 6, maybe 12 even doses to begin with, and then repeat every 10 minutes. Or you may give it continuously, and then you'll go down once you have a lower dose, once they're more stable. They will get hyperkalemia, they will get higher lactate, they will become tachycardic with this, just to know. But oftentimes we often use, there's some, in the Danish guidelines, they will say there's some evidence for using SABA plus SAMA, so the combination of ipratropium and salbutamol every 15 minutes instead. I haven't looked into the details of this, but I would probably give at least one dose of this and then continue with the SABA. But you can apparently just give both of them as well and go with this kind of solution as well. Most guidelines say that if you cannot give, if they're too bronchospastic, this is where I would probably just, as we say now, as this entire lecture is trying to suggest, we should probably go just to IM adrenaline. But if you for some reason don't do that, then you can give IM or IV tubulin, which is the same beta 2 agonist as inhaled in the dose of well, if you give it IM or subcutaneously, you'll give it 0.5 milligrams per milliliter. Or if you give it IV, then you'll do the enkelspät or diluted, single diluted solution, where you take 1 milligram per milliliter, which is the same as is in one of these tubulin ampoules, and then mix it with 9 milliliters of like a normal saline, and then you'll bolus it over 5 minutes, and you'll give some kind of corticosteroid, be the methazone or salmeterol, depending on. This is for anaphylaxis more so, but salmeterol is usually for asthma, and you can also give 30. In the Danish guidelines, it will say 37.5 milligrams of prednisone, and then you will consider, and these are the other drugs also in the extremist patients, like consider giving magnesium. After you've done all the adrenaline and intubated the patient and so on, you'll consider giving magnesium, 2 grams or 8 millimoles in 200 milliliters of glucose over 10 to 20 minutes, maybe more like 10. You can give the first bolus without many problems, but once you get several boluses, and you may have to give 2 or 3 sometimes, and the evidence is kind of weak on this, or at least it's on the fence. But once you give these amounts, there's a risk of respiratory failure with magnesium, and you will have to check the reflexes actually. But if you're intubated the patients, then it's kind of hard to test the reflexes, and then you have to check it in other ways that I'm not familiar with. So give magnesium once, but giving it more than once, it's getting into territory where I'll be unsure if I don't have an awake patient. And then you'll give, like, for the anaphylaxis ones, you'll get desloratadine for if they are itchy. Be aware of not giving them sedative drugs like Tavigil or Clemastine. You may give them antibiotics depending on the trigger, and NIV is not that good for asthma, but if you have someone who's stabilizing on the adrenaline that you're giving, but they're still like in a bad way, but they're awake and they're not quite ripe for intubation, then you can try to give them CEEP or Seropeep, or at least very low, like CEEP or CPAP or CPAP or of 0 to 2, but a higher IPAP, right, to blow some air in there. And then you may get low doses of ketamine. That's also, like, not intubation wise, but the ketamine may have a benefit in asthma as well. And you'll get the IV fluids as well. And you'll have a calm room. Okay. This is just to show that this is the guideline from Denmark, where they say kind of the same thing here. Give this SABA and SAMA. Give prednisone, consider antibiotics, consider other differential diagnosis, then reassess, and whether or not if they're still in a bad way, especially if they have normocapnia or hypercapnia, then you'll have to do more intensive stuff, and you'll call the anesthesiologist in Danish guidelines. But if you're the only one there, then you'll have to do, as we just talked about in the entire lecture, IM adrenaline, and so on and so forth. Okay, so thank you so much for listening, and please check out the AMAX 4 lecture series and the other links that I showed you. Thank you, and bye-bye.